Hello and welcome everyone to the discussion today. I am Dr. Rawa Abdul and I'm here with you for the group discussion to some of the questions of the antenatal care and its complication. What we are going to do today, we are going to wrap up what you have revised over the last week. And I hope that you have found the infographics of Dr. Nada useful for your revision, for the quick revision of the guidelines. Today, with the questions, we are going to clear concepts, okay? With every question, we want to make sure that you really understand the guideline in depth and you are ready to solve the exam questions, okay? So, shall we start? Okay, so let's say Bismillah, and the first question is very easy for my champions, and I'm saying, which is the recommended gestational week to start the aspirin intake for the woman at risk of preeclampsia? Yes, it's from the 12 weeks. And, you know, all my dear friends, you are aware, the rule of the low-dose aspirin also for the prevention of the placental insufficiency problems, right? And reducing the risk of fetal growth restriction in high-risk women. So yes, correct. This is the answer B. And the next question is asking, at what gestational age should uterine artery Doppler study be performed for high-risk women? That's to reduce the risk of small for gestational age as a form of screening. So, of course, the answer should be based on the new guideline. And based on the new guideline, the high-risk individuals are invited for the screening between 18 to 23 plus 6. Okay? Screening by the uterine artery Dopplers, okay? From 18 to 23 plus 6. Okay? So this is regarding the update one. What is the main surveillance tool for small for gestational age diagnosed fetuses? So now I'm not asking about the uterine artery screening. I'm asking about specifically the surveillance, the follow-up for a case diagnosed with fetal growth restriction. So follow-up, it must be by the umbilical artery Doppler. Yes, excellent. Well done, everyone. What should be done if a woman uterine artery Doppler is normal at the mid-trimester scan? A woman screened and she had uterine artery Doppler and it's normal. What shall you do? Okay. So which women will have the screening with the uterine artery Doppler? Is that routine for everyone? No, not routine. Is that for low-risk individuals? No, not for the low-risk individuals. This is for the high-risk individuals for the fetal growth restriction. Yes, well done, well done. So for the woman who is high risk for the fetal growth restriction, we will advise to have the serial ultrasound scan at 32, right? At 32, yes, well done. Everyone who chose A is correct. So what gestational age is recommended for birth in pregnancy with diagnosed with late FGR? Okay, so please remember difference in the definition between small for gestational age and fetal growth restriction. It's now different. So small for gestational age when the baby is just small in size, okay, less than the 10th centile and not less than third, okay? So we can say from less than 10 to 3 centile, okay, to the third centile. So this is the small for gestational age. No more delivery at 37 weeks for them, right? Now, if only the baby is diagnosed as small for gestational age with normal Doppler study, baby can be delivered from 39 to 39 plus 6, right? This is for small for gestational age, but here I'm speaking about fetal growth restriction. And fetal growth restriction, my dear friends, remember, from the definition, it's either baby less than third centile, okay, less than third centile, or the baby is less than 10 with abnormal Doppler, right? So if the baby is diagnosed at late FGR, then I will have to consider the delivery between 37 to 37 plus 6. Okay? Remember, this guideline, my dear friends, has stressed on the difference between the definitions of late FGR or early FGR, because this will make a very big difference in the plan for the delivery, okay? Correct? Okay, so the answer is from 37 to 37 plus 6. Dr. Azza, my dear, she's asking to repeat the question number 4. Is that correct? Is that your request, Dr. Azza? Okay, dear. So, my dear, a woman had a uterine artery Doppler and it was normal at the mid-trimester scan. Okay? So, if this woman had normal Doppler, okay? And he didn't say anything about the diagnosis of FGR. He just said that it was Doppler is normal. So what do you remember about that from the algorithm? We remember like this. Okay, I will make you today, inshallah, very familiar with this algorithm. Why? Because when you are familiar with the algorithm, okay, and we go through it once and twice and 3 times, you'll get used to it and you will copy it in your brain and your photographic memory is going to help you in the exam. Okay, so very important that you work through the algorithm, okay? It's a skill. So, Dr. Azza, my dear, which woman will have the uterine artery Doppler screening at the mid-trimester? The low risk people, or the moderate risk, or the high risk? We will have the high risk. Yes, excellent. Okay, so let's see in this algorithm, the high risk individuals, what they will have. They will have the uterine artery Doppler. Let me change my color. Okay, so they will have the uterine artery Doppler. Uterine artery Doppler at the mid-trimester scan will not be only for measuring the Doppler, but what will happen is that we will also check for the fetal weight, right? So if the normal uterine artery Doppler and estimated fetal weight is 10th centile or more, what shall I do? So here the arrow is showing you the answer. What is the answer, my dear? It's a serial ultrasound from 32 weeks, every 2 to 4 weeks until delivery. Okay, dear? So is it now clear for you, Dr. Azza, why the answer is that? Okay, so let's find what if it's a normal Doppler, but baby is small. Baby is less than 10th centile, and the Doppler is still normal. So we will increase surveillance of the baby, okay? And we will start the serial ultrasound from 26 to 28 plus 6, okay? Until delivery. This is the condition number 2 in the high risk population. Condition number 3, or the possibility number 3, is that you find that the uterine artery is abnormal. Once I found the uterine artery is abnormal, I'm not happy, right? Okay. So I will start my serial ultrasound from 28 weeks, every 2 to 4 weeks until delivery, if the estimated fetal weight was normal, means it's a 10 centile or more. So it's a normal weight, but abnormal uterine artery Doppler. Okay? Babies like this are at risk of both small for gestation age and preeclampsia as well, right? So we follow up from the 28 weeks every 2 to 4 weeks. How about in the condition number 4? This is the fourth condition here, that the scan show abnormal uterine artery Doppler and abdominal circumference or the estimated fetal weight less than 10 centile. So, my dear, can you please help me and tell me what is the diagnosis so far? The diagnosis now is fetal growth restriction because you have a small size baby with abnormal Doppler, right? Okay, so the answer here in the algorithm show you that a discussion with the fetal medicine, right? Good, but in the stem of the guideline itself, because not everything written in the algorithm, of course, in the stem of the guideline itself at the page 21 for the follow-up for the cases of high risk individuals, they advise to start on the ultrasound and Doppler follow-up from 24, okay, to 26. Okay, dear? Of course, but this will happen in the fetal medicine unit, okay? That's why you have to discuss with the fetal medicine unit, and for the further planning, will be individualized. Okay, okay, guys? Okay, yes. So, yeah, the abnormal Doppler, my friends, it's not only one condition. Abnormal Doppler, my dear, is in the condition number 3 and number 4. Let's repeat it again. Is it abnormal Doppler with normal weight? Okay, and this is the condition number 3. Or it's abnormal uterine artery Doppler with small size baby, less than 10 centile. And this is the condition, this is the condition number 4. Okay, so you need to check in the case. If it is normal size and the abnormal Doppler, the serial ultrasound is starting from the 28, right? Every 2 to 4 weeks until delivery. But if the abnormal uterine artery Doppler and small size baby proved by the abdominal circumference or the estimated fetal weight less than 10 centile, so here you will start early, okay? Okay, so this is the condition number 4, and this is from 24 to 26. Yes, Dia, yes, Dr. Benita, yes, correct. In the condition number 2, the serial ultrasound scan is started from 26 to 28 plus 6. Okay, you have to start in either from 26 to 28 plus 6. This is the starting time for the serial ultrasound scan for this baby, okay? And you will complete the follow-up until delivery. That's why, because this baby is small. Because this baby is estimated fetal weight is less than 10 centile. So in condition number 2, yes, it's normal Doppler, but the baby is small, right? Okay? If everything is normal in a high-risk individual, we have to start, and this is the condition number 1, and we have to start the serial ultrasound from the 32. Clear, my friends? Yes. Okay, that's well done. Okay, so let's go back to our questions. I think that we have finished the question number 5. Let's see question number 6. Oh my God, I'm sorry. I think I lost track. Yeah, it was question number 6. I'm sorry. Very important, my dear friends, that you go through the algorithm, and it's your time now. You have almost 6 months till your exam, which is a very good time, that you, every time you solve a question, you go back to the guideline, open your notes, okay? And clear your concept. Make sure that you apply, okay, the knowledge correctly, right? And by the way, the questions in the books now and in most of the question banks are still not updated for the new guideline of the small for gestational age and fetal growth restriction. So you have to revise only new updated ones. And in case you have all the question, let's make it like an exercise. Open up your new guideline and find what will be the answer. Okay? So here, which measurement interval is recommended for a woman at low risk of fetal growth restriction? Okay, so Dr. Adila, my dear, if you just wait, okay, a few minutes, what I will do is I'm going to go through the guideline quickly with you, okay? And with our friends who are maybe new to this guideline and they didn't still clear their concepts, okay? So low-risk individual, what we will advise? What the form of follow-up for them? The form of follow-up for them will be the symphysis fundal height, right? And this is no more frequently than every 2 weeks, right? We are advising symphysis fundal height every 2 weeks, right? Or next question, I'm sorry. Yes, it's 7. When should a woman with abnormal uterine artery Doppler start ultrasound scan? What do you think, my friends? A woman with a normal uterine artery Doppler start ultrasound scan. Okay, so B, excellent, everyone. Yes, correctly. Okay, so this is from 24 to 28 plus 6 weeks, right? And it's written in the stem of the guideline, not written in the algorithm at the end. In the algorithm, they mentioned individual, refer to the fetal-maternal medicine unit. Okay? Okay, in the question number 8, my friends, we have a 24-year-old in her second pregnancy. She had a history of a small baby, less than 10 centile, and she had a scan at 24 weeks, which shows the baby growing. Growth is is 50 centiles. 50 centiles, so that means it's normal, right? With normal amniotic fluid and Doppler. So what is the next step in her management? Previous baby was small, okay? And she had a scan at the 24 weeks. Current baby is 50 centile, so current baby is normal. With normal amniotic fluid and Doppler. So what is the next step in the management? We need to ask ourselves, right? If she is a moderate risk or she is a high risk individual, right? Okay, so woman with a moderate risk category, she is at risk of what? early onset FGR or late onset FGR? If she is moderate risk, so she's at early onset FGR risk or late onset FGR? Late onset FGR. Excellent, Dr. Han, and excellent, Dr. Laila. Okay, so what our algorithm says for a woman at moderate risk, okay, and here we will find that moderate risk means in the obstetric history, she had a previous small for gestational age, or previous stillbirth baby, but baby was appropriate for age. The baby who died, unfortunately, was in the appropriate age group. So we have small for gestational age in our case. That's why we put her on the moderate risk group. And the advice is that we do an anomaly scan and check the fetal weight. If the anomaly scan and the fetal weight is normal, it's fine. So we will commence serial ultrasound check from the 32 weeks every 4 weeks until delivery. Correct? So remember what is the reason behind the starting the follow-up or the close surveillance from the 32 weeks. The reason behind that the woman who is at moderate risk factor for small for gestational age is having risk of late onset FGR. So that's why we will start from the 32, which is late. Okay? Okay, friends? So the answer should be options again. Let's repeat the question again and see the options and compare to the answers. Okay, so Dr. Khan requiring, okay, to repeat the question again. So repeat the question again, no problem. Today is the day of clearing concepts. Look, my dear friends, it's a very good exercise that I will advise you to do, is that you go through the question and then open the file of the guideline or the guideline summary, whatever your notes is, okay? And clear the concepts, revise this part so it will stick to your memory, right? Okay, so Dr. Khan, my dear, again, the question says 34 weeks in her second pregnancy. She had history of a small baby, less than 10th centile. So this will put her at what kind of risk? Low risk for gestational age, or moderate risk, or high risk. So we know now that only history of a small baby is moderate risk. Moderate risk, okay? She had, okay, that's a very good question. She had a scan with a gross and a Doppler is done, and it even showed that everything is normal. Myself, I advise you, okay? You never doubt or question, okay, what happened in the scenario. Why did she have a Doppler? I'll tell you why. Because, my friends, not all the units follow the same protocol, right? So let's say we are asking about a woman who coming, okay, from a certain unit or something, okay, where they apply this protocol. Not everyone is MRCOG, right? So, okay, what happened is happened. Let's take it from there and answer it in the exam. Don't, overthink why they did the Doppler. Okay, fine, they did the Doppler, no harm, okay? So now I have to deal with the situation. normal gross, normal everything. She's at moderate risk. Where does this take you? This will take you to the moderate risk category in the algorithm, right? Directly, we go up there, okay? Guys, don't look to the answer. I'm just searching for a page where the algorithm is there, okay? This is the moderate risk group. When everything is normal, she will have serial ultrasound from 32 weeks every 4 weeks, okay? No, they didn't say FGR. They just said baby is small, right? They just said baby is less than 10 centile. And when I tell you baby is less than 10 centile, what will you call this baby, Dr. Azza? You will call this baby small, right? Small for gestational age. Yes, excellent. Well done, Dr. Sidra. So here, woman is at moderate risk category, and she's at risk of late onset FGR, okay? And so she requires serial assessment of the fetal growth commencing at 32 weeks. For the majority, okay, the interval between the scans will be 4 weeks, and this will be appropriate, okay? Okay, so I quoted this from the guideline in the answer. Okay, so now we have the question number 9, and this is a 32-year-old woman in her first pregnancy. She is seen at the 28 weeks of gestation. She had a gross scan due to symphysis fundal height measurement below the 10th centile, okay, which is an indication, of course, for referral. So the midwife was measuring the symphysis fundal height. She found that it's below the 10th centile. She sent her for a scan. The gross scan, showed that the estimated fetal weight of less than 5th centile. Okay, so in that exact question, they only wrote less than 5th centile with normal amniotic fluid volume and umbilical artery Doppler. So what will be your advice? What comes next for this lady? Before we go to the option, because this is an EMQ question, okay? Okay, so I need you to see, please, the options, okay? And you guys advise me, please, okay? You are going to help me today with the answers. So what do you think? Where does this take you in the algorithm? Guys, it's very, very important, okay, that you understand the situation correctly and go to the algorithm and apply the situation. You will have a very good skill if you remember the algorithm by heart. Okay, so, and this will be from the repeated exposure and repeated dealing with the situation, okay? Okay, so let's see what is this situation in the algorithm. Could you please tell me which condition is this in the algorithm? Where shall I follow the answer, okay? I'm now searching. What is the situation? Would you please tell me which part in the algorithm? Is it the moderate risk pathway or high risk pathway? Of course, it's a high risk pathway, right? Okay, so high risk pathway, is it the condition 1, 2, or 3, or 4? Okay, Doppler was normal or Doppler was abnormal? Please focus. Baby was small, but Doppler was normal. Okay, yes, well done. Yes, that's my champions. So, yes, normal uterine artery Doppler and estimated fetal weight less than 10 centile. What shall I advise? Serial ultrasound from 26 to 28 plus 6. Excellent, well done. right? Yes, I'm so happy and so proud of you guys. Why? Because you are now able to locate yourself, okay, the case on the algorithm. So now you can do it yourself, okay? You don't need my help afterwards, okay? Yes, well done. Okay, so proud of you. Now we have the question 10. And the 26-year-old patient is seen in the antenatal clinic. She is now 29 plus 5. And she had a symphysis fundal height below the 10th centile. She had an ultrasound that showed the estimated fetal weight below the 5th centile and normal amniotic fluid volume and absent in the diastolic flow in the umbilical artery. Okay, and the CTG is normal. So now, which condition is that? Okay. Look, my dear friends. It's in the condition number 4. Okay, but in our algorithm, the previous one, okay, they just wrote here. Yes, Dr. Sedra, I'm so proud of you. You got it. They just wrote here discussion with the fetal medicine. However, they didn't complete, okay, what should be done for this lady at the follow-up. But this is not the only algorithm in this guideline. There is another algorithm, right, for diagnosed FGR babies and their surveillance. And that's it, okay? So here, what was a gestational age, please? Because in this algorithm, I will teach you something. I'll teach you the trick here, okay? In this algorithm, they show you what is the follow-up before the case is diagnosed already with FGR, okay? Like our case here. So, and then he will divide the cases into cases diagnosed with FGR before the 32 weeks in the pregnancy. What we call this group, my friends? When the fetal growth restriction is diagnosed before 32 weeks. What I will call it? I will call it early FGR. Well done. Well done. Okay? And then he subdivided each group to the gestational age for the timing of delivery only. Okay? But then again, he gave you another group where the FGR, okay, this is the second group, okay, where the FGR is diagnosed from 32 to 36 plus 6. What will I call this group? Late, yes, okay. And then he give you also from term when the small for gestation age or the FGR is diagnosed at term, 37 weeks onwards. Okay, so my friends, such case when I have already a diagnosed case, already she had fetal growth restriction, what will be the form of follow-up? The form of follow-up for any case with fetal growth restriction is by the umbilical artery Doppler, right? Good. So the umbilical artery Doppler will be done every how many weeks? Follow-up for a case of FGR must be by umbilical artery Doppler, and this will be done weekly umbilical artery Doppler. Okay, every time I check it's normal, I repeat it next week. And how about the estimated fetal weight measurement of the fetal weight will be done? Every 2 weeks, 2 weeks, okay? Every 14 days, fortnightly, okay? For the weight. Okay, so I will keep it that way as long as it's normal Doppler. So or normal umbilical artery Doppler. So baby is small. Let's say I have a small baby. The size is less than 3rd decentile. This is FGR now by the definition. Okay, I follow up by the umbilical artery Doppler. Umbilical artery Doppler is normal, so I will keep on following up the umbilical artery Doppler every week until something happened which considered as a turning point in the follow-up. What is this event? This event that the abnormal Doppler now becoming abnormal. So the umbilical Doppler become abnormal once I have abnormal umbilical artery Doppler. Okay, I will stop surveillance using the umbilical artery Doppler and alone, and I will add ductus venosus and or computerized CTG. And in the new guideline, the computerized CTG comes first, right? And it's written here in this algorithm. If I have absent end diastolic flow or reversed end diastolic flow in the umbilical artery Doppler, monitor minimum twice weekly with computerized CTG and or ductus venosus. Okay? And this will apply to all the FGR till completed 34 weeks. Once completed 34 weeks, no rule for the ductus venosus. And the follow-up will be by the CTG, computerized CTG. Okay? Okay, my friends? Can you find it here? So I need you to be more familiar with the algorithm. I need you to be expert in interpretation of this algorithm. So one of my dearest students, he told me in the course, is that algorithm for human beings? This is impossible. No, it's not impossible. We can do it, right? If we understand the trick and understand the direction in the algorithm, so simply we can understand what's happening and we can solve the questions. And this is what all matter here, right? So my champions, if you have diagnosed FGR, early FGR, what is the follow-up with normal Doppler? Very small baby, less than 3rd centile with normal Doppler. What is the follow-up? Estimated fetal weight weekly or fortnightly? Fortnightly. Estimated fetal weight, no measurement of weight. Now, okay, less than 2 weeks interval. So 2 weeks for the estimated fetal weight. Remember this. But the umbilical artery Doppler is the one that will be done weekly. Okay, so Dr. Sana, my dear, will speak about diagnosed FGR case. Once the umbilical artery Doppler show abnormality in the diastolic, absent or in diastolic flow or reversed, what will be my surveillance tool and what is the interval? It will be the computerized CTG, minimum twice per week, plus or minus ductus venosus. Clear? And how I would decide for delivery? I will decide for delivery based on the abnormality in the CTG according to the gestational age or abnormality in the ductus venosus, right? So when the ductus venosus turn abnormal in a case, what will you advise? I will advise delivery, right? Right? If you had abnormal CTG, like, for example, spontaneous repeated deceleration on the CTG, deliver, right? Okay, good. Okay, so is that So far, the part that we have explained from this algorithm, is it clear for you guys? We have only explained this part so far. Clear, right? So we need to understand what is this all about. This is all about the early FGR or late FGR. What is the form of a follow-up? It's written here in the blue box, okay? And what will happen if the umbilical artery is normal? We will increase surveillance and we will change the mode of surveillance to minimally twice per week with computerized CTG and or ductus venosus, okay? Let's go back to the options. And you will find that it was written there in the options, okay? Okay, dears? So, in the options, the situation here, F, okay? F is the best match, right? Okay, so let's move to the next question, if you don't mind. Next question is 11. A 26-year-old patient is seen in the antenatal clinic and she is 29 plus 5 weeks of gestation and she had the symphysis fundal height below the 10th centile. Okay, doctor, are you repeating the same question? No, it's not the same question. This is an MQ. So please, guys, wait and complete reading because this is what happened in the real exam. Okay, you sometimes find two questions very similar to each other, but will be a change in the details or sometimes in the leading sentence in the scenario, which will make your answer different, right? So let's complete. Below the 10th centile, she had an ultrasound scan that shows estimated fetal weight below the 5th centile and normal amniotic fluid was absent in the diastolic flow in the umbilical artery Doppler, okay? And the CTG is normal. During follow-up, situation remains the same, okay? So what is the recommended time for delivery? Guys, please remember the Doppler show absent in diastolic flow. So if it is absent, your delivery will be at 34 weeks after steroids. And if it is reversed, it will be 32. Yes, excellent, Dr. Han, excellent. Dr. Sidra, yes, and Dr. Farzana. Yes, excellent, my friends. Okay, so here, please check. Same case, and now we speak about the delivery. The case who diagnosed with the FGR at the 29 weeks, with the Doppler is absent in the diastolic flow and followed up by the CTG, computerized CTG, and or the ductus venosus. Everything stayed the same. So he is now asking you about the delivery, and here is the delivery plan notice, and they wrote in this box, deliver by 34 weeks if absent in diastolic flow, the umbilical artery Doppler, and consider from 32 if other factors, okay? If it is reversed in diastolic, it will be by 32. And here it's written, deliver by 32 if reversed in diastolic flow, okay? Doppler, okay? So when you see the Doppler is absent in diastolic flow, choose 34. When you see it reversed, choose 32. Okay, friends? So very important, my dear friends, that what you do, be familiar with the algorithm, understand correctly, clear your concept, and apply, okay? Every time when you apply the scenario, you are going into another level of understanding, right? Okay. So yes, this is our algorithm, okay, in the EMR-COG, okay, and it's a bit different. It's just similar to the previous one, but it's a bit different. So at 29 to 30 plus 32, this is early FGR, okay, and we advise for them once the Doppler show absent in diastolic flow or reverse it to monitor every 2 to 3 days with computerized CTG and or ductus venosus unless delivery is indicated. For this group, okay, then we generally consider after 32, deliver by 34 weeks, and consider from 32 if reverted into diastolic flow. Same meaning, okay? However, if you stick to one algorithm, I will be happy. 18-year-old woman in her first pregnancy, she had a gross scan at 20 weeks of gestation due to high BMI of 37, okay? And the gross scan show that estimated fetal weight is more than 10 centile. Amniotic fluid volume is normal and umbilical RT Doppler is normal in this case. However, okay, don't please question the examiner why the umbilical RT Doppler is measured in this case. He is just now asking you, what is the plan of management? So what do you think, guys? What you will advise this lady now? Yes, she will have a serial scan. And from when we will start the serial scan, dear friends, for the cases with obesity, we advise to start from cases of obesity is different from the cases of congenital abnormality. So if the woman is having high BMI, right, or she had, for example, fibroids, okay, which make the estimated Simpson's fundal height is, you know, properly incorrect. So the method of the follow-up will be by the ultrasound. Cases with congenital abnormality in the uterus, also it's difficult to follow them by the Simpson's fundal height, even if the case has no other obstetric history as indication for the small for gestational age screening. But case is difficult here. Please remember, this was at the bottom, last thing, the orange one, okay, in the algorithm, and it's wrote here, if the anomaly scan and the estimated fetal weight is normal or 10 centile or more, so serial ultrasound from 28 in women with congenital uterine abnormality, and from 32 for the woman who is unsuitable for Simpson's fundal height every 4 weeks until delivery. Okay? Okay, so yes, this lady, she will have a serial ultrasound assessment every 4 weeks until delivery. And this is started from the 32 weeks. Okay? You got the point, guys? Okay. For each of the following clinical scenarios, select the most appropriate next step. A 34-year-old seen in the obstetric triage unit out of hours at 26 weeks of gestation with acute pain, tenderness, and the swelling of her left leg. She is otherwise well with no chest pain or shortness of breath. So what you will choose? Here in that scenario, we have changed the topic, okay? So when he asks you next step, okay, the answer usually will be the step before the recommended treatment. Okay, so if I ask you a question, my dear friends, what is the recommended investigation in this case? What is the recommended investigation in this case? This will be the Doppler, the duplex ultrasound on the leg, of course, yes, correctly. Okay, so the question here, my friends, what is the difference between next step in the management and the recommended investigation? Next step in the management usually will be one last step before you commence the appropriate management. Yes, starting on the heparin, even the heparin is recommended before the scan. Okay, before starting on heparin, anything that we can do, let's have a look to the options and tell me, please. These are the options of this EMQ. Okay, friends. So I can see here, some suggested B. B is compression duplex ultrasound. We even said that the low molecular with heparin will be before the ultrasound. It's not the recommended investigation or the best investigation or even the golden tool for diagnosis. It's a next step in the management. G is full blood count. B before G? No, Dr. Rafa, actually. Look, my dear. Yes, G before treatment. Yes, correct. So what will happen when you have a case, okay, especially that he mentioned that this is out of hours, means that this is after the hours, you know, the official hours of working, which is from 8 to 5, Monday to Friday in the UK, right? So the case came in an emergency situation, and in the emergency situation, okay, means that I could start the treatment before I arrange for the Doppler. Doppler can take time, but starting on the treatment will be actually more easy, right? And it can save her until the radiologist is available, right? Good. For the safety of starting the low molecular weight heparin, you have to check by the biochemistry. You have to check the full blood count. This is the step before even the low molecular weight heparin. Urea and electrolytes, liver function test, and coagulation test, right? Okay, so we don't start low molecular weight heparin, my friends who choose the K. We never start low molecular weight heparin without investigations. It's a safety. Okay, so because safety is first, and because he is asking you in this MQ about the next step in the management, you have to understand the trick in this MQ, okay? Not to resist it, okay? So we are understanding the tricks, okay? We learn from the questions. So when you find next step, this is very much different from appropriate management plan or recommended investigation, okay? Appropriate management, that means they need the specific management for this case. But what is first, okay? What we do first, Dr. Azza, we do investigations in the cases of the DVT. And the investigation aim to rule out contraindication of use of low molecular weight heparin, right? This is the value and the aim of the investigations. What investigations are recommended in the guideline? Full blood count, urea and electrolytes, check for the liver, for the kidney function, check for the liver function, and the coagulation test. Why? Because simply, if this lady had a prolonged ABT, ABTT or PT, can I give her low molecular weight heparin safely, for example? No. Okay, so this will be the investigation. Then, followed by starting on the low molecular weight heparin. This is the correct event, sequence of event. Then the recommended investigation is the duplex ultrasound for the leg. Okay, so the duplex ultrasound for the leg, if it's found to be normal, what you will do based on the ultrasound? The guideline told you if the duplex ultrasound is normal, what you will do? Stop the low molecular weight heparin. So which one came first? The low molecular weight heparin came first, right? Before the low molecular weight heparin, even you have to do investigations, right? This is for the DVT. If we revise the algorithm for the pulmonary embolism, okay, because the guideline has only one algorithm and the algorithm is written for the pulmonary embolism. Do you remember this one? If we divide this algorithm, my dear friends, you will find that simply, okay, they will advise the investigation before starting on the low molecular weight heparin, right? So let's have a look. Yes. Okay, so it's time to clear concepts, and I'm going to change my presentation, guys. So let's revise together the sequence of the event. Okay, so again, welcome back. This is algorithm, very famous algorithm of the acute VTE event in pregnancy. The algorithm at the end of the guideline is only showing you the suspected pulmonary embolism, but it's the same pathway will be done for the VTE, and we'll go through it. Okay, the suspected PE, what you will do, clinical assessment, perform a chest X-ray and ECG, test the full blood count, urea electrolytes, and LFTs, and commence low molecular weight heparin, right? If there is signs and symptoms of the DVT, what you will do? You will perform a compression duplex ultrasound. Okay, so starting on the treatment is first or scan is first? Which one came first? Treatment first, right? The leading scenario of this EMQ, the leading sentence in that scenario was, what is the next step in the management, and not asking what is the diagnostic investigation or what is the recommended management for this case, okay? Or what is the golden test, okay, to diagnose. So guys, be careful of that question. And by the way, my friends who are expert in the MRCOG Part 2 preparation, they know well that this is a question from respected Dr. Andrew Caesar book, right? Yes, exactly, Dr. Faiza. In cases of emergencies, the treatment is first, and before the treatment, we have to do the biochemical investigation, okay? No, D-dimer is not one of the investigations that we will perform in pregnancy in cases of suspected VE. Why? Because the D-dimer itself is increased in pregnancy, right? The question 14 is, for the following clinical scenario, select the most appropriate next step in management. Again, next step is required. And next step can be very small action that you would do in the clinic, for example, okay, or in the emergency department. It's next move, okay, not final destination. So a 38-year-old patient who is seen at 22 weeks of gestation with acute swelling and pain in her right cuff. She was started on therapeutic dose of low molecular weight heparin and had a Doppler ultrasound scan, which was negative for deep venous thrombosis, and she remained symptomatic. So if the case now had in the DVT, be careful in the DVT, if you find that scan is normal, what you will do next? Stop treatment, right? The treatment that we have started already, stop it, right? And based on the clinical assessment, if low risk of clinical suspicion mean, for example, the pain and tenderness subsides and no clinical now picture of the DVT. So it's fine, plus finished. Stop the low molecular weight heparin. But if high clinical suspicion and the symptoms remain, you stop treatment and repeat the scan when you will repeat it at day 3 and day 7, right? Yes, excellent, everyone. Your answer is correct. And here are the choices, and please choose one option that match your choice. Which option you think is the best? Yeah, we will stop treatment and repeat the scan in 3 days. Correct? Yes, that's correct. Well done, everyone. So for each of the following clinical scenario, select the most appropriate next step in management. We have a 22-year-old patient at 35 weeks of gestation presented with chest pain and shortness of breath. She had a sinus tachycardia and chest X-ray is normal and laboratory investigation are normal, and she had been started on low molecular weight heparin. So what you will do in this case, what the algorithm says. Okay, so the algorithm says there is another step that we will do, right, to confirm our diagnosis, okay? So since the chest X-ray is normal, okay, we will go for the VQ or the CTPA. I told you maybe even before, okay, that I myself remember CTPA with the abnormal CTG, so I match A with A to remind myself, okay? So when I was in the same position as you, as my friend, I used also to be confused between the algorithms and, you know, which one to do here and there. Okay, so I had to find a way, you know, to link it and remind myself. And I'm sure that you find your way as well. Because the only difference actually between you and me is just the time. That's it. You know, guys. So the only thing that I have been there before. That's it. Okay. So I'm trying to guide you in the correct way, based on the evidence, okay, and with the careful application of the guideline recommendation. So here, let's have a look again to the algorithm quickly, and we will have symptoms and signs of DVT, yes or no. In our case here, it didn't mention, so we will go to the no pathway. In this no pathway, he is asking you, go back to the chest X-ray. If the chest X-ray is normal, go for the VQ. And if it is abnormal, then you go to the CTPA. If the pulmonary embolism is confirmed, so everybody now is having a rest and the patient will continue the therapeutic dose of low molecular weight heparin for 3 to 6 months according to her condition. And if the pulmonary embolism on the VQ or the CTPA is not seen, okay, so we will have to stop treatment or continue. What do you think? That's a very important trick. Will you stop treatment or continue? If you have evidence, no evidence of the pulmonary embolism in the scan. Okay, so pulmonary embolism is a life-threatening condition. And since it's a life-threatening condition, it will be different from the DVT, okay? For the DVT, we choose to stop the treatment and repeat the scan if there is high risk of clinical suspicion. But here, if the clinical suspicion is still high and the case still have the symptoms of pulmonary embolism, which are serious and severe, like, for example, patient had chest pain, dyspnea, some of them will have low oxygen saturation, okay? If I have such clinical picture, I will never stop the low molecular weight heparin, okay? So on high clinical suspicion, okay, I will continue the low molecular weight heparin. On high clinical suspicion, I will continue low molecular weight heparin, okay? And consider alternative or repeat testing, okay, since I have high clinical suspicion. If the pulmonary embolism clinical suspicion is low, okay, so it means that situation is changed, pain is gone, she is okay, or appears to be another thing, then low clinical suspicion, okay, plus finished. I will stop the low molecular weight heparin because I got another diagnosis. Okay, my friends? So high clinical suspicion with the pulmonary embolism, remember, we continue the low molecular weight heparin while we are searching for the alternative or considering repeating scan. Okay, this is a very big difference between the two conditions, the DVT and the pulmonary embolism, right? Okay, my friends, are we happy so far? So dear friends, what I will do now, okay, yeah, I will ask you to have a break, okay? And then we are going to clear some points after the break. So break for 5 minutes if you don't mind. Thank you very much.